Hi everyone, I'm Dr. Belinda Dickie. I'm one of the pediatric surgeons here at the Colorectal Center at Cincinnati Children's Hospital Medical Center.
And I'm Monica Holder. I'm one of the pediatric nurses at the Colorectal Center.
We're hosting tonight's event because we're here that there's a lot of families who are interested and have questions about the treatment of anorectal malformations. So just briefly, my background is I'm a pediatric surgeon here at the center, which means that I've done general surgery training with additional training in pediatric surgery as well as colorectal surgery for kids. In addition, I have done minimally invasive training, and I have training extra with vascular malformations.
I've been a nurse here at the Colorectal Center in the outpatient department for 6 years. And prior to that, I worked on the inpatient unit with GI and the colorectal patients for the previous 6 years.
So I just wanted to go describe briefly what our program offers to patients and parents here. We have a multi-collaborative center where we involve both urology, gynecology, and if needed, neurosurgery, GI, and any other specialties that are required. We look at patients from a global view, looking at every aspect, including their anorectal malformation. We help with the surgery as well as the pre- and post-operative management, including bowel management.
And we're very excited about the large number of you joining us here this evening. Feel free to go ahead and start submitting your questions, and we'll get them queued up here, and we will see how many we can answer here in the next hour. Please ask each question only once, and Dr. Dickie and I will answer as many as we can in the next hour.
So there's just a general question about anorectal malformations and the different types. So we can briefly describe about girls and boys. With boys, most often parents do or may or may not know prenatally whether their child has an imperforate anus or an anorectal malformation. If it's a lower type malformation like a perineal fistula, this will most likely not be picked up on prenatal examinations. Some of the potential other ones with a fistula to the urethra may be seen on prenatal exams only because they see dilated colon or there may be associated renal issues. The other types of boy malformations that we talk about in general are rectal bulbar. The bulbar urethra is a part of the urethra that's near the beginning towards the penis. Then there's the prostatic urethra, which is between that and the bulbar area and the bladder, and then finally a bladder neck fistula. Within girls, the different malformations are very similar to the boys, but because there's an extra organ in there, the vagina, the malformations are described differently. So there's once again the perineal fistula, there's something called a vestibular fistula, and the vestibule is the area of mucosa behind the vagina, or the area of pink tissue behind the vagina. And then finally there's something called a cloaca, where the baby is born with only one opening, which connects to both the bladder, the vagina, and the colon.
So one of the questions there is stating that the child has an imperfect anus, and the question is, will they be able to potty train when older? So as Dr. Dickie was talking, there are many different types of malformation, and different malformations have different prognosis for bowel control. Do you want to talk about that?
Yeah. So when we talk about bowel control and the prognosis of bowel control, we don't look at just one thing. There's multiple things that we have to address, and there's multiple things that we look at when the baby is born. So the first thing we look at is where the malformation is. So like I described beginning before, whether it's a bulbar, a perineal, a prostatic, or a bladder neck will determine partly what your continence are. If you have a good surgery that fixes the anus with a perineal fistula, if bearing there is no other abnormalities, which I'll talk about briefly in a minute, a perineal fistula should have up to 100% chance of bowel control. Bulbar fistulas have anywhere from 85 to 90%. Prostatics have upwards of 60%. Bladder neck has 15%, and no fistulas have about 90%. This is if there is no associated other malformations, and the other things that we help predict control is looking at whether the child has a tethered cord or not. The presence of a tethered cord will decrease the chance of continence. And as well, we look at the sacrum. So the sacrum is the tailbone or the very end of the spine. If there is a short sacrum, and we look at something called the sacral ratio, but it's a little bit complicated to describe without an x-ray in front of me. If there is a short sacrum, there is a higher chance that the child will not have bowel control. The other things that affect bowel control is if there's something called a presacral mass, and that is once again picked up on imaging once the baby is born. Do you want to add anything about that?
Well, I think the next thing that the families are interested in, if they cannot have continence by potty training, then what do we offer for that at that point? And that's when we offer bowel management, where you come and we teach you what enema that you will give to your child, and you will have an enema specifically tailored to your child that you give once a day to artificially clean the colon, and then the rest of the time there will be no stool passing. But that enema has to be specific for your child, and we figure that out through our bowel management program, which is a 1-week outpatient program.
So I think Mel has a question that asks similarly about issues of continence, and her son was born with a high imperforate anus, so it sounds like he had a bladder or bladder neck fistula. We can, as Monica said, if they can't get continent on their own, so continent meaning they can feel and they can go to the bathroom and stool on their own and be clean in between, we can help you and your son get him socially continent, meaning we give them an enema once a day to get them clean, and then between enemas, which are roughly 24 hours apart, you don't have to worry about stool accidents. The next thing, of course, related to that is urine accidents and being dry for urine. And sort of the same things are used to predict whether a child can have urinary continence. Once again, we look at how high the malformation is, the presence of a tethered cord, and the sacral ratio. So once again, similar to fecal continence, if all those things sort of stack in the favor of not incontinence, we can get the child socially continent and dry. Doing intermittent catheterizations, and that's why we have a multidisciplinary collaborative clinic where we work with our urologists so that we can work on both things together.
So Amanda's question, I think, kind of leads into that. How long do you have to do enemas before trying to see if they have bowel control? Not 100% sure I know what the question's asking, but to kind of answer, our 1-week program we use to find what enema will keep your child socially clean. Some patients we feel like may have potential for potty training, but sometimes at age 3 with a malformation that might be a little bit more difficult with the maturity level and them just wanting to pay attention to their body's needs. So for those patients, sometimes we offer an enema program initially at age 3 when they need to be in regular underwear, and then about 6 months or to a year later, then we can have you come back and trial stopping the enemas and seeing if they can then potty train once they've gained some maturity. I'm not sure if that fully answers the question. If there's still some clarity needed around that, then we can answer that as we go.
So there's a couple of questions regarding cloacas and their chances of continence, and sort of similarly, like we've already started discussing, we look at multi-factors. So of course, you know, the shorter the common channel is, the better the development of the muscles. There is the higher chance of continence that way, but we also at the same time look at the tethered cord presence or absence, and we look at the sacroracial presence or absence. With the higher common channels, the sacrum and the pelvis is a little less well developed, and if you look at your child's bottom, if it looks very flat, that often is an indication that there's not very good muscle development down there, and those chances of continence are decreased. But once again, even though they cannot be fecal and urinary continent, we can keep them dry and socially continent and clean of from accidents of stool.
And we feel like the best time to do that is when the parents feel like they are ready for them to be in underwear. So for some children that might be 3, and for some that may be closer to 4. It really just kind of depends on when they are ready to send them to school and when the other kids around them are in underwear. So we have that a little bit gauged by the family as well. And there's a question about how do you join our bowel management program. Julie's asking if a referral is needed. Our center does not require any referrals. We will accept anyone with the malformation or fecal incontinence. That is a little bit guided though by your insurance. If your insurance requests that you have a referral, then that might be something that has to be done, but the center itself does not require a referral. All you do is call our main number, and we can probably, well, we have that posted as well. Call our main number, which we can have posted. It's 513-636-3240, and just let them know what you're calling for.
So there's another question about a cloaca and the indicators of potential normal bowel control in a low common channel. So I think, as we've discussed already, the things that we would look for here, usually a newborn infant, I can give you a scenario of a newborn infant that is born in our hospital with a cloaca, and we know through imaging that it is a short common channel. We always image for the cord, so they always get an ultrasound of their spinal cord. At the same time, when we ultrasound the spinal cord, we look to make sure that there's no presacral mass. When they're newborn, we also get sacral x-rays to look at the length of the sacrum. And then prior to surgery, we get more imaging, and we also do a cystoscopy and a vaginoscopy to look at the length of the common channel and see where the rectum takes off. And see where the vagina takes off and the bladder takes off from the common channel. And all things put together can help us decide whether there's a potential for bowel control. Even though we give you numbers saying that, you know, a certain group of patients has 60% or 30%, that doesn't mean your child has 60% chance of being incontinence. That really just means 60% of all children presenting with this sort of malformation have continence. So my philosophy is, if there's any chance, even if it's a minimal chance, and the parents are willing to work with the child, I always give the child the benefit of the doubt, because we will have some children who we would say have no chance of continence become continent. And then there's some children who we think are going to be continent have no continence. But once again, we can still get them clean. We can have them in normal underwear. We can have them going to school with not having to worry about accidents.
Okay. Tricia is asking, their child currently does daily enemas, and how and when do you make the decision to do the Mace or Malone procedure, and what criteria is? We have many patients doing rectal enemas, and the criteria that we kind of use to gauge if a child is ready for a Malone procedure is that they are on a current enema routine that is clean, and they are socially continent, and then when the child is asking for independence. So at the time that the child is ready to start taking some independent care, we think about doing it at that time, and that's for safety of the track that's done during the operation, so that it's not damaged with passing of the tube. And Dr. Dickie, I don't know if you want to comment. Sometimes we do it earlier if we're in the abdomen.
So I don't know if everybody knows what the Mace procedure is. So the Mace or the Malone or the appendicostomy, or some people will even say cecostomy, those are different alternatives to give an enema. So when we talk about enemas, we're talking about rectal enemas, where you actually give an enema from below. Doing the Mace procedure, doing the appendicostomy or the Malone or even a cecostomy, is giving an enema from above, meaning that instead of flushing from below, we actually flush from the beginning of the colon down. The Mace or the Malone or the appendicostomy is actually where we take the appendix and tack it up to the abdominal skin, so there's a different way that we can enter into the colon to give the flush. If there is any chance that the child needs any other sort of urological reconstruction, if they need something called a Mitrophanoff, which is a way to do caths from above instead of below, we try and combine those two procedures together, because sometimes we use the same We use the appendix and we can split it and use it for both. We are in the belly anyways, and so it's nice to save one surgery. And by coordinating, we can come up with a coordinated plan for the patient. Usually, though, urological reconstructions don't happen until they're about 4 to 5 minimum years of age, and so it sort of works out for the time that we would do a MACE or an appendicostomy as well.
Mel's asking, her son had a pull-through at 8 months of age and still at 2 years of age is continuing with a rash and has tried multiple creams. So oftentimes the rash is due to multiple episodes of stooling, which is what causes the irritation. So sometimes we use our bowel management program with a daily enema to treat diaper rash, even before we're asking for social continence. So at 2 years of age, we don't expect the child to be in normal underwear, but oftentimes we will do a daily enema to have the colon empty once a day, and then the bottom can be free of stool passing, which will allow for skin healing. Also, we would need to look at the length of the colon to see if there needs to be any slowing of the GI tract, if there needs to be any additional things that we can do to make the stool thicker or slow it down. And that's depending on the individual case, and I think we would have to see a little bit more information to know for sure, but definitely we would think about bowel management to help cure the diaper rash.
There's a question about the sacral ratio. I mean, the sacral ratio is not necessary for treatment, but I think the sacral ratio is a nice guide to help predict whether a child has continence or not. And that's what we use it for. If you have a normal sacral ratio, we can help predict that potentially the child would have a higher chance of continence. If it's a shorter sacral ratio, then we say that the risk of incontinence is higher. So there's a question about a child who is 3 with a cloaca that doesn't have continence, and will they develop continence with age? So I think that most kids with imperforate anus and most kids with anorectal malformations may potty train later than kids who don't have one. And the reason is they don't have the same sensation that we do as we go to the washroom, that you feel the pressure down at the bottom. So what the child feels instead is a cramp in the belly, and that takes more processing and more ability to relate that cramp in the belly means that I have to go stool, and not necessarily there's a pressure down at the rectum, which means I have to go stool. So even if the child isn't continent at 3, doesn't mean that the child won't become continent. Usually what we do is if at 3 they have to be clean for school, we'll start with enemas. They learn how to be clean, learn how it feels to be clean, and then yearly after that we will test them to see if they can manage without enemas. And sometimes kids are 5, 6, 7 years of age and they learn to be continent. This is bearing in mind looking at all the different factors that we talked about before, the tethered cord, the sacral ratio, the type of malformation the child has, whether they have a good predictive to be continent.
So then Erica is asking about her child having the ostomy reversal and dealing with constipation and any suggestions. So our treatment for constipation with any patient with ARM is to use a senna-based laxative. So what we typically do at that time is about 1 month after the colostomy closure is to get an abdominal x-ray and see the degree of constipation. And then if there is constipation, we start on a senna-based laxatives. Senna liquid for the little ones, X-Lax chocolate chews for our school-age kids, X-Lax pills for the older kids, and we treat them with the senna-based laxatives at the dose that is needed for that severity of constipation. So we don't dose by age, weight, height, anything like that. We start on a dose that we feel might be helpful, and then we follow with x-rays and reports from the family to see if we're giving the right amount. And we will adjust that as needed to the point that the child has a good soft form bowel movement at least once a day, And then that's when we know that there's enough laxatives, also with an x-ray showing that there is no constipation in the colon.
So there's a question about body signals and not having to use enemas and taking medicines. So similar to what we discussed about, they learn a different signal from their body. That's their signal that goes stooling. It was interesting that in clinic the other day, there was a mom who found out that the son actually told her, it's a cramp that I feel that needs to go to the washroom instead of feeling from below, whereas everybody had always assumed he felt from below to make him go stool. So these are just things that the child will learn as they get older, that their signal is, and that's bearing in mind that, like we talked about, the other issues for continence are there.
There's a couple questions about asking about having partial sphincter muscle or lack of sphincter muscle, and if there's any treatment for that, any repair for that, and having bowel control.
So there have been in the past ways to do artificial sphincters and try and reconstruct the sphincters, but there's nothing that has been reliably shown to help in these children. There are ongoing studies and ongoing research, and we are actually looking at a couple of different things at our center to see if we can apply them to children with anal rectal malformations. You may have heard about sacral nerve stimulation. We also are looking into what's something called Celesta, which is actually injecting a filler almost to bulk up the muscles. These things have been used sparingly in children just because they've been first tested in adults, but we are trying to learn how we can apply these to our children in our center.
The first question, Amber is asking about having a colostomy reversal and multiple stools, and asking when the intestines will wake up and stop stooling so often. So this is the number one thing that we battle when you have a colostomy closure. Is diaper rash and multiple stools. So what's typical is when you close the colostomy, the portion of the bowel that hasn't been used doesn't really know how to do its job yet of absorbing the water, and so that's when the baby or the patient has a lot of liquidy stools, and so that's what's happening initially right after the colostomy closure. And then it's typical over the next 1 to 4 weeks for that portion of the bowel to kind of learn its job on how to absorb the waters, and that's when the stooling will start to slow down. So that's typically between 1 to 4 weeks. But the thing at that 4-week mark is you have to watch for the constipation. So at that point, some constipation is significant enough that it also can cause multiple stools if the child is stooling around a lot of hard stool or impaction. So we kind of watch for that transition in the first few weeks, and we also follow with the x-ray so we can know for sure if the stooling is due to the bowel still trying to absorb water, or if we need to start treating for the constipation.
So in addition to that, if the pull-through was done with rectum, that is going to help. Sometimes if there's not enough rectum and actually colon is pulled through, the child may end up stooling more than the normal 1 to 2 times a day. So, but you know, we in our center at about 1 to 2 months will always get an x-ray just to check to see where the stool is and if there's any buildup of stool, because like Monica said, we often see what's called overflow incontinence, or where there's a hard ball and nothing can pass by the hard ball except for the liquid stool.
And then in that time period too, we also kind of work with diet to be on our side. If the kid is truly stooling too much because it is liquid stool and needs to absorb more waters, then we will offer more constipating foods at age-appropriate levels. And then when you get to the point of constipation, we will offer more laxative foods to help with the constipation. So dietary is much important at that transitioning period.
There's a question about rectal washouts and panic attacks, about having their son having rectal enemas. we try and talk to the children. I know it's hard to reason with a 5-year-old, but I think once they learn that it doesn't cause them pain, and once they learn that it makes them feel better, most kids are pretty willing to go ahead with continuing with enemas and washouts. Sometimes we do, at least at our center, we have child life, so distraction is a good technique. So, you know, getting them the iPad out or watching TV while you're doing to distract often helps that.
Ashley has a question about, do any of our bowel management children get off of enemas and go to the bathroom normally without enemas or medication? And just as quickly mentioned earlier, we do have some patients that we do feel like as they get older may be able to be continent and potty trained, but sometimes they just need some maturity. So we will do the bowel management program first, and then each year we can offer for them to trial stopping the enemas and seeing if they can potty train. We have many of them that are successful, and we have several that we follow many years, and as the child starts asking, they will come back and try again. But to answer the question without medication, that would be specific. Some of those children need to have a laxative to keep the colon moving, or some of them may need Imodium if they have a fast-moving colon. So we would have to evaluate specifically each child to see if they need those medications.
So for a child, as they get older, for them to get off enemas and potentially to be on laxatives and to stool and to be able to feel, to go to the washroom without accidents, there's a number of different factors we look at, and most of them deal with how the stool moves through them. So you heard Monica talk about fast or slow. So we always get a contrast enema on these children, and that gives us a good indication whether the colon is dilated, which means they move pretty slow, versus not being dilated, which means they probably move fast or don't move slow. So for a child to be completely continent in this scenario of an anorectal malformation, we have to have the colon moving at a rate that allows them to have control. The stool has to be the right consistency. So if the stool is too loose or too liquid, they're going to have troubles controlling it. So that's why we add the fiber, and we add potentially if they needed Imodium to slow them down. But it has to have enough bulk for them to hold it in and to feel it. And then we need them to the stimulation. So that's where we add in the laxative to give that extra stimulation so that they will be able to feel it and have the feeling to go to the washroom.
And that kind of leads into the next one of being on a specific dose, and will it ever be reduced or will it need to be increased? And the answer to that is some children are able to reduce it if you can offer some dietary options, but often the constipation is at a level that dietary alone will not be enough for them, so they usually will need some laxatives, and in combination with the dietary needs, sometimes it can be a lower dose. And will it need to be increased? We do have many patients that do need to be increased over time, and we also have some that will maintain at the same dosing for a period of time as well. So we really just watch each child and adjust as needed for their specific colon needs.
So I think that leads into Jean's question, asking if children can ever get addicted to laxatives. So I don't think it's really an addiction, but they need the laxatives to go, and it's more of a stimulation for the colon. We don't know how, the mechanisms completely of why the children get so constipated, but I think with the extra stimulation of the laxative, that's what helps them go. It's a medicine that they need, just like a child with a heart problem needs heart medicine. So we don't really call it an addiction, but they most likely will rely on having to use the laxatives for life. So people always ask about the side effects of the laxatives. As far as we know, Senna is a very old drug. It's actually a herbal medicine. I can tell, or people who scope or look at the inside of the colon, whether a child's been on Senna, because it actually tattoos the inside of the bowel, but it doesn't really change the function of the bowel.
Nina has a question about, do we always do MRIs on babies with ARM or imperforate anus in the U.S.? Our typical screening process is that we do a spinal ultrasound on babies 3 months and younger to check for tethered cord, and that can be checked to about 3 months of age. Beyond 3 months, the spine calcifies, and you can see it as well on an older child. So above 3 months of age, then we do screen with an MRI. So it is our common practice to screen for tethered cord on all babies with ARM.
So the MRI, as Monica said, is actually to look at the spinal cord. We don't get we will get an MRI in specific cases depending on when the child comes to us and for different reasons for their workup. As a newborn, we do not get an MRI on most babies unless there's an indication otherwise to do so.
There was a question earlier that I saw, someone asking about vomiting with enemas. Our recommendation is that prior to giving an enema, you want to make sure in general that the child is hydrated and to not give an enema on a full stomach. They can have food and drink prior, but we just ask to not have a full meal just prior to giving an enema because it can often make them nauseated or vomit. You might want to wait about an hour after giving a full meal to give the enema just to prevent that. And keeping them hydrated will also help with any headache side effects or the enema not being as effective because it will retain some of the enema solution.
There's a question about x-rays and the necessity of x-rays. We use x-rays quite often because it gives us a good indication on the stool load. It's hard sometimes on clinical examination, even with rectal exams and even with palpating the belly, to feel the amount of stool, and that is our reason for getting x-rays, because sometimes we're surprised at how full a child will be and they're impacted without showing that clinically.
There's a question about, Erin has a question that her son has frequent vomiting and headaches with his dosing of laxatives. In general, we monitor the children to see how they tolerate the dose of laxatives that they're on. The vomiting we see as the dose of laxatives increase, as the cramping can increase, and often the cramping can also be associated with some vomiting. I don't tend to see headaches as often with X-Lax, but we definitely at higher doses of laxatives can see them with severe abdominal cramping, which can lead to the vomiting.
I mean, the headaches could potentially be related if he's stooling a lot, that he's dehydrated. So sometimes, encouraging good fluid intake may help with some of that.
Dana has a question saying that initially her daughter was doing a daily enema, and now that she's older, they skip enemas on some days. Is this okay to do, or is she backing up? That question the way we would answer that is on a day that the enema is skipped, to get an x-ray and find out how backed up. You're going to be watching to see if she has any soiling in those days that you're skipping. If she remains clean, then oftentimes we'll work with the patient and see if that patient is someone who can go with having an enema, skipping some days, or enemas every other day. But that's only after you have established an enema routine on a daily basis and you have established social continence on a routine basis. Then we can see if skipping an enema on some days is still going to be effective on cleaning the colon and staying socially continent. And we would use an x-ray to verify that and also make sure that she stays clean.
There's a question on urinary reflex, so I'm just going to briefly address the urological system with the anorectal malformations. We are very proactive in our center for monitoring and looking for renal issues, because we know that the higher the malformation, there is the more association with urological issues and with urinary reflux. So we routinely screen our children for reflux. We also routinely screen them with ultrasounds to make sure that there's no damage to the kidney, and those are with renal ultrasounds to look at hydronephrosis. And that is why at our center we work very closely with our urologist, and so they will do most of the screening, and they will follow along with us to make sure that the kidneys are safe and don't suffer any damage.
Christine's commenting about her son had a rectal prolapse repair done and has another prolapse. Recommendation on surgical repair with recurrence.
So it depends on the malformation that your son has, and I think it also depends on the development of the muscles at the perineum or at the bottom. So if your son has a very flat-looking bottom, sometimes the prolapse is more will happen more often, and it's difficult to completely solve the prolapse issue. As well, if he strains a lot to stool or if he strains to pee, sometimes that will make the prolapse worse. When we repair the prolapse, we usually fix depending on if it's one side or both sides, we will do it as a local operation, and then we're very careful to manage the constipation afterwards so that they don't strain.
I think another thing we kind of talk about is if the prolapse is interfering with the quality of life. So we always talk about if it is sticking out enough that it's rubbing on the clothes, causing bleeding, mucus deposits that might be going through the clothes. Some parents aren't ready to have the prolapse repaired yet, and we basically gauge that also on if it's interfering with the quality of life. It's important to know that it is not medically urgent and there's not a big risk associated with it as long as it's not interfering and doesn't cause a lot of bleeding and mucus coming through the clothes.
So our indications for prolapse repair is if there is staining or mucus that causes problems, or if there's bleeding, or if there's pain. And often if there's a mild prolapse, we'll leave it if the child doesn't have any issues with it. There's a question about strictures following surgery, and if so we will start dilating a child after repair 2 weeks after repair, and we actually follow a pretty strict protocol until we know that the anus has healed well. As you know, when we repair the anus, it's a circle, and the job of the body to heal is actually to contract. And so when you contract a circle, it gets smaller. So the point of dilations is actually to keep the circle large enough as it heals until the scar has completely healed and stopped contracting. If the strictures recur and there's a problem with the stricture, we usually look to see if there's a reason for it. Sometimes an anal stricture will recur over and over again, even after repair, if there wasn't a good dilation protocol, or if there's something causing the stricture. And some of the things that we worry about is poor blood supply when we do the repair to the colon, or sometimes with the presacral mass, there is a stricture that you can't dilate it, and then that needs to be fixed.
Jennifer has a question, 14-month-old on laxatives for the past couple weeks and is not stooling but every few days, asking if it's too young of a time frame to start enemas. So in general, as we talked about earlier, we start our bowel management enema routine when the child needs to be socially continent. So that's usually around potty training age. Usually up to that point, we do manage the constipation with laxatives. And our recommendation is that any child with constipation and ARM does have a good bowel movement at least once in every 24-hour period. So our protocol is that depending on the dose you're on, if there is no good bowel movement in a 24-hour period, we give an enema to evacuate the stool content that's currently in the rectum. But at that same time, we also increase the dose of laxative you're on continuously, because that proves that the dose you're currently on is not enough to create a bowel movement every day. So we do give an enema to evacuate the rectum at that time and increase the current dose continuously.
So there's more questions on anal dilations, and so what I can do is just review our protocol for anal dilations. We start dilations 2 weeks after surgery if there's no contraindication to it, and usually if there's more extensive repair to the rectum, we may delay that till 4 weeks after surgery. But for this, our standard is 2 weeks after surgery we start dilations. And our dilations start at a certain number, so you would come to the office and we actually calibrate the anus to see what size dilator fits comfortably without causing any pain for the child, and we teach the parents how to do that dilation. We dilate twice a day, and each dilation each dilation session, we pass the dilator twice, and we hold it in for 30 seconds. There's a certain size based on age. And so I'm not going to go through all the sizes, but once you reach the size that we feel is the appropriate size for your child, then the dilations continue twice a day until the dilator passes easily. Once the dilator passes easily, which sometimes can take up to a month or two, then we start to slowly wean the dilations down. And we first go to once a day, and that's done for a month, and then we go to every other day, and then every 2 days, and then every week. So our dilation protocol may be more prolonged than others, but that's just for our insurance that the anus doesn't contract down while it's healing.
There's some questions about a child being on a specific enema with just water and still soiling, wanting to know if another solution would work better. That's what our bowel management program is designed to do, is find the exact enema ingredient that works best for your child. It's different for different children. If the tap water enema is not working, we use enemas that have a base of normal saline, which is your body's natural saline solution component, and then we add different additives to that enema specific for your child. So we have different additives that we use. We use glycerin and we use Castile soap as two of our main ingredients, but the amounts of those are determined specifically for your child, and that is determined through our week-long outpatient program.
So there's a question about post-operative care and what the mom can do post-op after having surgery for a cloaca. So really the issues post-operative, everything is done from above, is as adequate care of the perineum, so where the repair was, and the incision. Usually there's no issue with the diet initially, but the diet issues come when the colostomy is closed. And so we have a very, once the colostomy is closed, we're very careful about talking to the parents about constipating foods and trying to avoid the constipating foods. Doesn't mean that they can't have any, it just means to limit the amount of constipating foods. We want the child to move after surgery, sit up in bed as soon as possible, to hold the child. The thing that you don't want is to straddle the child, so the child can't go in the jumpy chairs where the legs are spread apart.
They still can use all of the safety features of seatbelt buckles and car seat buckles and stroller buckles. So it's more of the pressure added between the legs that we are preventing. So we often, to help that, we will put 2 diapers on the child if they're still in diapers after surgery, just to kind of help protect that a little bit more. So they will be in 2 diapers for 1 month.
There's a question about a spinal ultrasound coming back for a tethered spinal cord, and whether there's a repeat MRI done when they are older. So usually when we find a tethered cord, we refer to our neurosurgery colleagues. Depending on where you are and what part of the country you are, some neurosurgeons will repeat MRIs, some won't, and some of them will repair based on symptoms. So I'm going to defer that for you to talk to your neurosurgeon, but we do talk to our neurosurgeon whenever we find a tethered cord.
I think the question, if it's initially not tethered, is there a risk for it to tether?
If it's initially not tethered, it's probably not going to tether in the future.
Nina has a question that her child has never had constipation since the colostomy closure, and questioning is that a sign of incontinence or if it's common. I don't know if you want to answer.
So we usually say the constipation is worse when the malformation is lower. So the perineal fistulas, the vestibular fistulas, the bulbar fistulas usually have worse constipation than the ones that are like the bladder neck or the higher common channel cloacas. I don't think it's an indication at this point in time that he's not going to be incontinent. You may just have him on a very good diet. Most breastfed babies are not constipated, and if you are pushing, fruits and vegetables, you may be able to avoid having issues with severe constipation.
Ruthie has a question about a child who had been on an enema routine for a long time that was working and now is not working and what would the next steps be, and the physician is wanting to remove some of the colon. Just in general, the enema that is determined during the initial bowel management period may be an enema that works for a long period of time, or it may be an enema that needs to be adjusted as time goes on and things change for that child as they grow, as their dietary habits change, as their hormones change. So it is typical. We follow all of our patients for life, and it's typical that the enema needs to be adjusted as they get older. So the families will send us a report of what's going on along with an x-ray, and we will change the enema additives to meet the needs of the child at that moment. And it is typical that some need to be changed frequently throughout as they get older.
There's a question about Peristeen. So Peristeen is relatively new to the United States. I know that people in Europe and even people in Canada have used Peristeen more than we have. We have started using Peristeen in a select number of patients. We have found that it works better with the older patients, and it's just because of the catheter that's been developed and the balloon that's been developed that it seems to work better in the older patients. Sometimes we have to adjust the enema that we may have been clean on with our rectal enemas with the Peristeen system, because it is more of a flush upwards than just letting the fluid drip in. I think Peristeen is an alternative way to give a rectal enema, and I think it gives the older patients more independence and able to do it on their own as opposed to having parents help. And I think it's an alternative to having a Malone or an appendicostomy. The Malone or appendicostomy really is to give a patient independence, and if you can gain independence with the Peristeen system, I think that's another alternative that patients and parents can consider.
Gary is asking if there's a limit to how much senna you can give to a child. We often need to give an even start with a dose that's higher than the recommended dose on the box. That's pretty typical, so there's been no side effects for going higher than the recommended dosing. What you seem to find is that you get to a dose that maybe the child cannot tolerate with symptoms such as abdominal cramping, the vomiting that we touched base on before. So once we reach that dose to where the child is symptomatic and can't tolerate because of vomiting or cramping, that's how we know that we've reached the upper limit for that child. But that dose can vary greatly among different children. We have some that start experiencing that at maybe 4 and 5 squares, and we have some that tolerate up to 10, 11, and 12 squares. So it's really individual for each child.
So there's a question about from Nadia about her 22-month-old who has multiple small bowel movements through the day. So this could mean an indication that the child is constipated. So our sort of signs of constipation is if you pass little tiny, I call them rabbit pellets throughout the day, or if the child has little smears throughout the diaper and not having a good empty. Those are sort of signs that the child might be constipated, and potentially in these kids, especially with the 22-month-old, we start with little small enemas, and what we like to use in our hospital is the little glycerin suppository enemas, which is the little bubble, and they help empty the child quite well. The best way to find out if the child is constipated is, of course, to get an x-ray, which you've heard multiple times throughout the last few hours.
Ruthie is asking if there's a test you can do to figure out what works for the enema or if it's just trial and error. Our program for the bowel management, we start off with a contrast enema that gives us kind of a map or a picture of the colon, how dilated it is, how narrow it is. And based on our many years of experience, that gives us a good indication on where to start, how much additives might need to be given, and that's basically just based on our experience over the years, and that's our starting point. But then we do need to use trial and error for the rest of the week. Now we do have some guidelines that we have learned over the years based on the report you give, what is happening in between the enemas. We have some guidelines that we're able to follow on deciding if the additives need to go up or down, or if the saline solution needs to go up or down. But it is trial and error to some point, and based on the experience that we've had over the years, we do have some guidelines to get us to the end point fast.
And I think, When a child comes to our bowel management program, sometimes, looking at the contrast study and from our collective experience, that we are able to get the enema right off the bat, and you're clean for the rest of the week. And there are some children who it's a little bit harder, and we have to work together with the parents. And I always tell the parents and the child that we're a team together, that we have to work on this, and sometimes it takes more than just the week long to get it right. And sometimes when you go home, even though it was right during the week, 2 months later, things you're having accidents or you're having problems. So if that happens, we keep working with you. The week doesn't mean that we lose contact with you. We have a very dedicated team of nurses that works where I would assume the majority of their day is dealing with bowel management, phone calls and emails from parents, and troubleshooting and trying to figure out what's going on. So bowel management is it helps your child get clean, but it also takes dedication from both the family, from us, and from the child to want to work on it.
And that leads into Ashley's question about how long do we recommend staying with an enema routine before seeing if they can come off and potty train on their own. In general, we would say probably at least 6 months, sometimes a year, and sometimes when the child is interested. But I would say in general, we say about 6 months and then to a year. And a lot of families will gauge that on trying to come back to our bowel management program when the child is on a school break. So whether that's an extended spring break or a summer break, and that will give them the opportunity to be more successful with trialing off of the enemas. How about Amanda's question at the top?
Amanda's question. So Amanda has a question about her first child having a perforated anus, and what are the chances of the second child having a perforated anus. So as far as we know, there is no genetic link to determine imperforate anus. However, if their child has something called Currarino's triad, that we know does have a genetic sort of link, but that happens through different generations. And Currarino triad is a child with an imperforate anus, a sacral anomaly, and a presacral mass. And those kids, that family may have a higher chance of having more than one child with an imperforate anus. There's a question regarding high concentration of enema solutions, and so we try and get the least concentrated enema possible that will work for your child. Long-term wise, the overstimulation of a colon can cause potential problems regarding pain, inflammation. We have not found this with the concentrations that we use, because we try and limit the concentration of the additives that we do put in the enemas.
Let's see.
There's a question about patients outside of the U.S., and so we try and help as many patients as possible. And if the insurance company and if you're able to come and see us, we are more than welcome to have you come visit us in the United States for bowel management.
The question about how can you tell if a child has, I think the question is asking if they have fast motility or slow motility constipation, and what age is that typically determined. With us, we see patients at various ages. So for us, we determine when we see them at the first initial visit. But the patients that we see initially and operate on, we know right from the beginning if they are going to have constipation based on some of our experience. But we do follow our patients closely. We get reports from our families, and we follow with x-rays to help see the stool load on the x-rays. I don't know if you want to add anything.
So a lot of parents come and ask us about motility testing and manometry and the utility of it for bowel management, and how it would help determine whether a child is constipated, what the treatment basis would be. In our center, we work closely with a GI colleague who does do manometry, but if it's straightforward, meaning that we can get a contrast enema and we can get the child clean with an enema, then I don't go ahead and do manometry and motility testing. And the reason is that requires another anesthetic. It's an invasive procedure. Whereas the contrast enema doesn't require anesthetic, and it gives us a good idea and a good sense of what the colon looks like and how well it empties. If we have troubles, so if we have troubles getting the colon clean, if we can't quite understand why the child keeps having accidents, or the colon is very dilated in certain portions and we're worried that those portions don't work, then those may be indications that we do further testing with manometry.
Nasser is asking if there are any children with anorectal malformation that are not using either laxatives or enemas. We do have some patients that can balance the constipation needs purely with diet, but we don't use that as our first line of attack, because most of these kids are either toddler age or school age, and it can become very difficult to regulate diet exactly. And make sure they're getting all the right foods and vegetables. And it becomes a little bit more of a power struggle with their diet plan than it's worth for the constipation issue. So we recommend that they are offered in general the same foods that the rest of the family is offered, that the whole family is offered healthy foods and fibrous foods, and that then you regulate them with the laxatives. And we say not to fantasize that diet alone will be enough for many of these children, because many of them with the perfect diet, the perfect amount of laxative foods, still will have constipation issues. I know there are families that kind of work with herbal diets and those kind of things, and we work with you on that, but we do say just to be very careful and monitor closely if you are trying to do things without the medication, because some of it is very difficult.
So there's a question about diaper rash after colostomy reversal. So we are very, very proactive about diaper rash after colostomy reversal. Right after the colostomy reversal, usually the first day after surgery, we have parents and the nurses on our floor know to protect the skin, and we start with there's different products that you can find out there. What you do is just find the one that works for you to protect the skin right away. The child has never stooled before, so the skin there is sensitive, and so that's why we start protecting immediately. If the child has a severe diaper rash due to stooling frequently, that's when we may treat them with just little small enemas, and it's usually the glycerin enemas that we use. So they stool once or twice a day instead of constantly through the day, which will help keep the diaper rash. We also encourage, as soon as a child stools, not for the child to sit in the dirty diaper, but to clean it right away. And sometimes it helps just to have the child be without a diaper for a while and air it out.
I think some of the typical products that we're using is Sensicare and Criticade.
So we do have a protocol in our hospital where they start out preventative with Criticade, and they start that even before there's any sign of a diaper rash, just for protection. After that, we will upgrade to the Sensicare, and there's calmoseptine and the zinc oxide creams.
And I think the most important thing for the parents is to don't rub the skin. Rubbing the skin breaks it open very easy. We have you just pat the skin, and if there's cream on it, and when you're patting the skin, if there's some stool that remains just on the cream but not on the skin, do not forcefully rub to get all of the cream off if the stool is just touching the cream and not the skin, because that rubbing can break the skin open very easily. So just a lot of patting, and not to use wipes and deodorized things that have fragrance, to use just plain gauze and water. There's a question about the difference between glycerin and Castile soap that's used in the enema. Glycerin, they're both irritants on the colon, they're both soaps. The glycerin is a little bit more irritating, and the Castile soap is a little bit more gentle. So when we want an enema to be stronger, we'll use the glycerin first. If we need something a little bit more gentle, we will use the Castile soap. They're both products that can be found in either online or in the grocery store, more of like your hypermarts. You can find the glycerin often in like a cosmetic aisle. The Castile soap is more organic, so you can find them more at the organic aisle, the hand soap aisle, or like a GNC store. And the Castile is also a home care item, so it can be ordered from your provider.
So I think our final question for the night is from Julie, and she's asking about bowel management program and what we do for preschoolers and whether it's just enemas or there are alternatives. So really our bowel management program is either laxatives or enemas, and we base it based on the potential of the child to have bowel control. If your child at preschool age is already potty trained for urine and there are good indications that the child could be continent for stool, then we would potentially try first with laxatives. However, if your child is not potty trained and there is indications that the child will be fecally incontinent, it's much easier to start off with enemas first so that we can get the child clean and we get the child in normal underwear before starting school and not having to worry about accidents. Do you want to finish? So I want to just thank everybody for joining us tonight. We hope that you've had some of your questions answered and you had that the information that you received was helpful. Please call us at 1-877-881-8479 if you would like more information about our program. And we would really like to help you if you want to come and see us.